So someone wanted to know about craniocervical dissections. And a dissection is a tear in the artery. It's often traumatic, but it doesn't have to be traumatic. However, the typical stem would be car accident or some sort of trauma. And so it's called cranio and cervical because even though most dissections are extracranial, they're in the cervical portion of the artery, they can propagate and extend into the cranial cavity. And so for the carotid artery, that's got a cervical portion, which is in your neck, and then it goes into your head. That's the intracranial portion. That's a petrous portion where it makes a bend. And then you've got an intracavernous internal carotid artery, and then a supraclinoid carotid artery. However, most of the dissections occur in the neck, and then they just propagate upstairs. The way that this comes to us in ophthalmology is because the sympathetics are around the carotid artery, traveling from hypothalamus down to the T2 level in the spine, exiting white rami, and then over the apex of the lung onto the internal carotid artery at that point from the superior cervical ganglion onto the internal external carotid artery into the head. And so the sympathetic nervous system on the cervical carotid can produce a Horner syndrome. And so that's how it comes to us. So an acute, painful ptosis, upside down ptosis, anisocoria greater in the dark because it's a sympathetic lesion, and ipsilateral Horners with pain after trauma is how the craniocervical carotid dissection comes to us. Now, the other artery that can dissect is the vertebral artery, and that is in the posterior circulation. And so the posterior circulation vertebral artery dissections produce emboli into the posterior cerebral circulation, so that means it can produce a homonymous hemianopsia or cortical visual impairment because two vertebrals become basilar. Basilar terminal artery is the posterior cerebral artery. And because those basilar perforators are going to the brainstem, they can have diplopia. So in a carotid artery dissection, the emboli are flying up into your eye or your brain. That's central retinal artery occlusion, branch retinal occlusion, or an intracranial stroke. And in vertebral dissections, the emboli are flying up the basilar into the PCA, the posterior cerebral artery, or its perforators at the brainstem. So you can see that craniocervical dissections can produce both afferent and efferent disease, can produce a Horner syndrome in either, can cause vision loss. If it's a two-eye thing, homonymous hemianopsia or cortical blindness, you should be thinking posterior circulation. And if it's ipsilateral, CRAO, BRAO, central retinal artery occlusion, branch retinal artery occlusion, carotid dissection. It can be traumatic, but doesn't have to be. And this is how craniocervical dissections come to neuro-ophthalmology.